So we're going to talk about, again, just scan the QR code. Just I think the interaction is very important, and the audience response is actually giving us a lot of very important feedback on the content and the design of the course as well. So this is the same patient. This is Dr. Hassani's patient, 55-year-old Ahmed, but now he's coming to the emergency room in an acute situation. So he's been under a lot of stress for the last 6 months, more smoking, less sleep, more work, and he actually comes in with acute chest pain. So now he's 55 years old, and just to add now, he's been smoking for 12 years, also inconsistent in taking any of his medications, and in fact, he reports he forgets to take his once weekly GLP-1 receptor agonist. So, anybody in the audience, please tell me what this is. I know there may not be cardiologists, but this is one you cannot afford to miss, right? Yes, ST elevation, where? So V1, V2, V3, 4, 5, 6. Now, can you also see the subtle changes here? Lead 1 and AVL. So this is what kind of infarct? It's a very extensive infarct. It's very large. So it's an anterior septal lateral myocardial infarction. If this infarct completes, the patient will probably lose most of his anterior lateral wall and have an ejection fraction probably of 20%. So in every city in the UAE and practically in every hospital, we now have cath labs. And this is saving a lot of lives, right? So the interventional cardiologist comes in at 2 in the morning, opens the vessel. It's a very proximal, tight LAD lesion from the first septal and the first diagonal included. So this would have been a massive infarct, right? So clearly we understand the gravity of this situation. Now, this is his readings in the CCU, right? So HbA1c is 8.9. Remember before it was 6.7. Blood pressure 146 over 77. And remember, supposed to be on a GLP-1 receptor agonist. Lipid profile, LDL 109, HDL is 35, triglycerides 168. Now, fortunately, because the interventional cardiologist came in within 60 minutes, the door-to-balloon time was quick, and the patient didn't have necrosis. But also, albumin-creatinine ratio and eGFR. So I'm going to stop here and look at these additional risk factors. Are you worried by these two numbers? Why is the cardiologist now talking about kidney function and all sorts of strange things like that, right? I learned this actually from my diabetes colleagues. I got a phone call when I work at Imperial Diabetes Center, and I got a phone call from the medical director, and he told me, you cardiologists are not checking the ACR or GFR routinely on our diabetic patients. And I actually, at that point, I was completely ignorant, and I laughed. I told him, I have echo, I have troponin, I have BNP. So he tells me, look, I'm going to send you this article. Just read it. And what did the article tell me? When the ACR goes up to 10, cardiovascular death and events increase by 70%. And if it goes up to 30, cardiovascular death goes up fourfold. And I was shocked. How can I, as a cardiologist practicing for 20 years, seeing thousands of diabetic patients, not know this fact? It's in fact more powerful as a biomarker than echo, troponin, and BNP. So we don't test it at our own risk. It's a hazard not to test. So now I've realized that even small increases of the ACR are very significant. Second question is this GFR normal? What is a normal GFR? What is normal? Above 90. But every single lab test I've seen in the country says 60. Where does 60 come from? That's the hazard between CKD 2, 3, and 4. So you have to remember that 60 is not normal. And most of your patients are actually about 60, if you think about it, right? And many factors go into this, including obesity, hypertension, uncontrolled diabetes. So I think these two have become very big red flags for me, at least as a cardiologist. I used to be bothered by a low GFR because I couldn't send the patient to the cath lab without hydration, and I couldn't send the patient to an MRI without some specific things. But now it's, for me, an eye-opener. It's more important than many other tests. So here was an opportunity, really, for SGLT2 inhibitor in this patient, yet another. Now, what about the LDL? Is anybody happy about the LDL? So in a post-MI patient, an ACS patient, what is the target LDL? Right, 50% reduction and less than 55, and it's actually a double thing. So if he's 109, if you divide that by 2, what are you going to get? 54.5. We made it 109 for a specific reason. So, what is the treatment you're going to give for a patient to lower their LDL by 50%? High intensity statin. What is a high intensity statin? Is it 10 mil? Exactly. So it's a completely different dose than is being used in general practice. It's atorvastatin 80 or 40 and rosuvastatin 20 or 40. Now, what's the average statin dose that we've seen in the ACS registries from Abu Dhabi? What's the average statin dose? 10 milligrams. That's not high, it's actually low intensity statin. It's wrong. So anyway, so this needs work. What about the triglycerides? Are triglycerides important as an atherogenic risk factor? Yes. High triglycerides, i.e. high VLDL or high non-HDLC, if you want to put them all together, also indicates risk, but after you treat them with a statin. So you first have to put them on a statin, lower the LDL maximally, and then look at the residual risk. I see a lot of patients taking omega-3 and not enough statin. Does that make sense? No, it doesn't. Why do people ask for omega-3? Because it's natural. It's not like that poison called statin. I'm just kidding, right? Because this is what the internet is circulating. If any of you have WhatsApp, in the last 2 days, I've gotten hundreds of WhatsApps about omega-3. There's something on CNN that omega-3 increases AFib. Anyway, so I've just described a lot of things. And of course, we can't forget the HbA1c. I mean, as a cardiologist, I have to acknowledge that even if the patient lives longer, but they're blind and they have an amputation and dialysis, they're going to hate you for that, right? So we have to address the microvascular complication equally as important. We cannot leave the HbA1c go up. And that's really kind of important. So in this patient, at least in the past 5 minutes, we've discussed a lot of missed opportunities that could have been done for this particular patient. So in 2 years, even though he got the excellent advice from Dr. Hassanein and was prescribed the right medication, something happened and he ended up with an event. So what was the issue here? Again, scan, and please, we want to see which ones impact more. Failure to prove it using first-line treatments. Failure to make risk factor modifications, failure to look at the patient's goals and needs, failure to diagnose, failure to support, and use advanced treatments. And while we're waiting for this to occur, I'm going to say that one of the most important things that the diabetes societies and the diabetes world has contributed is the structured diabetes clinic. The structured 3-monthly follow-up with diabetes educators, with physicians who are trained and focused on prevention has literally saved the lives of millions from dialysis, retinopathy, and cardiovascular disease. In cardiology, do we have such a structure? Absolutely not. There is zero focus on prevention in cardiology fellowship, in cardiology practice, and training. If you have a typical patient like this, they're going to get an appointment within 1 week. Somebody looks at their wrist for the radial axis or the groin. Are you taking enough Plavix? Do you have prescription? Ma'as salama, baba. That's it. Come back in 6 months. Or the patient has chest pain again and they bring them back for another cath. Zero focus on prevention, zero. So we really have to adapt the beautiful approach that diabetes centers and diabetologists do to cardiology and cardiometabolic patients. So most of you realize that failure to make risk factor modifications and failure to include the patient in the discussion and provide supportive care has this massive impact. So he's not taking the GLP-1 receptor agonist. He didn't see the diabetes educator. He didn't come for his clinic follow-up. We didn't support him as, look, you have high risk. It's not just a number. We need you to work on everything. So adapting the system to help the patient actually reduces worse outcomes, right? You can't just rely on the patient to do the right thing. They have a lot of competing interests, and health is not on their mind when they're primary prevention patients. So when he was seeing Dr. Hassanein, he was pretty healthy, and he didn't have a symptom. Now he is, and there's a lot of motivation. But we could have done a lot for this patient. So this is not a unique problem worldwide, where we don't prescribe the right medications. So this is the CAPTURE study. So CAPTURE study was a Middle East-based study, and they looked at patients with diabetes and established cardiovascular disease. 100% of these patients were recruited from specialized cardiology and diabetes centers. But every doctor knew that they had cardiovascular disease. And in 2020, the guidelines had changed to include risk-centric therapies. So only the minority of patients, 20%, out of 100% who would have benefited, were getting either SGLT2 or GLP-1, 10% getting GLP-1, 15% getting SGLT2. And this is in 2020, after all the guidelines and all the evidence had already been generated. So physician inertia is a big problem here. And this was in specialized cardiac and diabetes centers. The next study, this is in 2023, this is PACT-MIA. Dr. Fathiya and myself were part of the committee, and in the UAE we recruited a really large number of patients, and these were patients in primary care and secondary care. So this was 50-50. Primary care settings, we wanted to avoid the bias of being only in cardiology clinics. And this is the stunning fact. In all of the countries involved, 99% of patients were either high or very high risk. High or very high risk, which means they have to be on disease-modifying therapy, SGLT2 and GLP-1, intensive lipid lowering, the whole package, right? And in the UAE in particular, 30% of our patients with diabetes had cardiovascular disease as established atherosclerosis, prior event, imaging, a prior heart attack, stroke, or amputation. So very high-risk group of patients. So while we'll come back to the PACT-MIA in a second, but what would the glycemic target be for the patient now since he has type 2 diabetes and a prior event? So now he's had a heart attack. When you send him home to the hospital, what number are you going to give him? What target does Ahmed? Ahmed, you have to reach this number. Which number? Is it less than 7, less than 8, 7.5, individualized? Which number? So do you foresee any problems in a patient with a recent myocardial infarction having more intensive glycemic control? Remember, he's young, he doesn't have severe kidney disease, he's not on other treatments, and he's still obese. So most of you are coming up to less than 7. Is there any concern to getting him less than 7? If he was frail, if he was elderly, if he was already on other medications that could cause hypoglycemia, I would think so. Now, there's a false concern about hypoglycemia, which I think we wanted to tackle with this question, right? In many situations, and the patient himself says, I don't want to be on an injection, doctor. I'm afraid of hypoglycemia. Can you answer this question using evidence? The answer is yes. You use it in obese patients who do not have diabetes. Does it cause hypoglycemia? No. SGLT2 inhibitors, we use them in heart failure and CKD patients who don't have diabetes. Does it cause hypoglycemia? It does not. So the safety of both agents, or even in combination, is well established in randomized clinical studies and should easily translate in clinical practice. The caution, of course, if the patient is on sulfonylurea or insulin, and then you add GLP-1, then hypoglycemia can occur. Now, is hypoglycemia dangerous in the cardiac patient? It is, because severe hypoglycemia, which causes a need for somebody to help you, to be assisted by somebody else, is also associated with arrhythmias and QT prolongation and ventricular fibrillation. But just hypoglycemia on a CGM or a monitor isn't the same thing, because you can correct it, right? So we try to avoid hypoglycemia, but from the GLP-1 receptor data, actually we've seen less hypoglycemia, because these patients ultimately can be less insulin resistant and can be tapered down on insulin. So it's, I think, very reasonable to target less than 7, and individualization based on what factors? Maybe the patient has side effects. Maybe that's why he wasn't taking his GLP-1 receptor agonist. But I wouldn't talk about hypoglycemia as a barrier to adding very important therapies. And while we're at it, I'm going to ask you, what about SGLT2 inhibitors? Do we think that SGLT2 inhibitors cause recurrent UTI? Do they? No, genital mycotic infections, which are rare in the Middle East because of tahara. So recurrent UTI is often stated as a relative contraindication, and I've seen patients with diabetes, heart failure, and CKD being not prescribed these medications based on that rationale. So how would you then manage this patient? So we agree that he would benefit from a aggressive target, 7, less than 7. Would you start on an SGLT2, start on GLP-1, or conventional therapy, SU or DPP-4? Remember, his A1C is high now. It's 8.9, so you need more, right? So what's the benefit in general of SGLT2 inhibitors? What do? They reduce what in diabetes, primarily? New onset of heart failure, right? What else do? They protect against progression of albuminuria and kidney disease. So they're very valuable, okay? Now, in this patient who's had a cardiovascular event, this was addressed in 2 clinical studies, right? The DECLARE outcome study included patients who had diabetes and ASCVD, and also primary prevention, no ASCVD. And the EMPEROR outcome study had patients who were all ASCVD, all of them. 75% had an MI, 25% had other events like TIA and PAD, right? The only one of these studies, only the EMPEROR outcome study, showed not only an impact on heart failure, but an impact on atherosclerotic events, MACE. In the DECLARE study, only the patients who had a prior heart attack benefited from dapagliflozin to reduce MACE. So heart failure is the class effect of all SGLT2 inhibitors, but only one of them, and to a lesser extent in DECLARE post-MI, would an SGLT2 inhibitor be recommended. Now there's another reason to give this patient an SGLT2 inhibitor. What is it? It's CKD, mild microalbuminuria. Mild microalbuminuria. If you remember, the DECLARE study enrolled patients with a GFR above 85, right? So at any stage of the kidney spectrum, you're still getting benefit. So you see that it is. So statistically speaking, GLP-1 will give this patient the greatest benefit from atherosclerosis, right? The MI patients, stroke reduction from the LEADER study to PIONEER, SUSTAIN 6, and also, I'm blocking, EXCEL as well. So specific GLP-1 receptor agonists do reduce atherosclerosis. SGLT2 inhibitors have the heart failure benefit. So when we look at this patient, the scoring system that Dr. Fathia and Dr. Hassanain described is no longer relevant. The patient is now events. So where is he? Automatic, very high risk. There's no question about it. We've missed the boat. Now he's very high risk. So what do we need to do? Regardless of the glycemic control. So if I modified this case and told you the A1C was 6.1, right? You still have to give them GLP-1, SGLT2 inhibitor. You still have to. It's a little bit easier here because the patient's non-compliant and the A1C is higher. And if that's the case, as Dr. Fathia mentioned, you add, combine. And then once you've added those two, you're free to add whatever else you want in order to reduce the glycemic control. You don't want this patient to go blind or go on dialysis or develop neuropathy, right? So it's all things in one. So it's a mindset issue. You change your focus because of the risk, but you also add medications because of the A1C, right? And you can certainly give metformin on top. Blood pressure target, you must use RAS blockade. Must. In the post-MI patient who has no hypertension, why do we give ACE inhibitors? To prevent remodeling and prevent sudden death. Now, obviously, it's more important when the ejection fraction is low, but it's equally important even if the LV is relatively preserved. Now, LDL target, we discussed this, less than 55. And in this situation, if the patient's LDL was a little bit higher, say the patient's LDL was 140, if you give them highest intensity statin, the LDL will be what? 50%. So if the patient starts at 140, 50% of that is 70. Is that okay? No. Then you have to start high-intensity statin, ezetimibe, maybe even PCSK9. You have to achieve the number. You don't negotiate the target, you just find how to lower it, right? So at the very least, 80 milligrams of atorvastatin or 40 of rosuvastatin, reassess shortly afterwards. So remember, this patient was already on GLP-1 receptor agonist, right? So there's two reasons. So first of all, he wasn't taking the medication. We have to ask why. Was it an insurance issue? Was it a tolerance issue? Was it a side effect issue? Side effects are fairly common with these medications, but they can be adjusted and modified with specific interventions. High-dose statin, ACE inhibitor essential, dual antiplatelet, so you have to give him, it's a post-ACS patient. And remember, whether or without the patient having a stent, a post-ACS patient has to be on dual antiplatelet therapy, right? If you have an ACS that's managed medically, and this was from the Plato study, you have to give them at least 1 year of dual antiplatelet. If you have a patient who has a PCI, minimum of 3 months, up to 6 months based on the type of stent or intervention, an extended antiplatelet is also reasonable in some patients. Now, we're going to talk about beta blocker in the same slide. Is beta blocker automatic in any patient who's had a heart attack? Yes or no? So in the past, we would say beta blocker is a mandatory in all patients post-ACS. I want you just to look at this. This is the updated guideline, actually, from the European Society of Cardiology, and we've adapted it. Dual antiplatelet therapy, aspirin plus clopidogrel, at least for a specific duration, depending on the phenotype. Statins and ACE inhibitors. Beta blocker is not here. Beta blocker is here for symptomatic therapy, right? Now remember, one of the most miserable things that you get with a beta blocker is symptoms. If you have a male patient and you put them on a beta blocker, you won't stop hearing about it every clinic when they have erectile dysfunction. It's going to come up every single time. So always review the indication for beta blocker, right? It's a good therapy if a patient's tachycardic. If it's a good therapy on top of ACE or calcium channel blocker and they're not controlled and they have coronary artery disease. It's a good therapy if they have heart failure. But if they don't have any of those, the only other remaining reason to do it is to treat angina. If there is no angina, you don't have to continue the beta blocker, right? I'm not saying withdraw it. Carefully look at the list and decide why the patient's on it. Do you have angina? No, I don't. Thank you. Remove it. You can also use nitrates, non-dihydropyridine CCB. Amlodipine is commonly used in these patients. Why? Because you can treat the hypertension and it also reduces angina and doesn't have as much side effects, right? Trimetazidine, ivermectin, and ranolazine for management of symptomatic coronary artery disease. So no symptoms, reduce their medication. Their medication burden is a problem. Now, one point here that's related to long-term antiplatelet therapy. When you see a patient on aspirin, I know the ASCEND study recommended discontinuing aspirin in diabetics because of primary care. There's an increased risk of bleeding, there's a slightly decreased risk of MI, it's a wash. But don't routinely discontinue aspirin without finding out why the patient was on it. If it's a primary care prevention, by all means, risk-benefit analysis. But if the patient has had a whole stent 10 years ago, or had a PAD, or has an abnormal ABI, or had carotid plaque, or had an abdominal aneurysm, think about this, because I'm seeing routine removal of aspirin in people who've had prior events or had remote events. So just check. Meanwhile, can we use long-term Plavix? We can. Long-term antiplatelet therapy has been studied in two large studies, the CURE study and the Pegasus study. And in those patients, addition of long-term dual antiplatelet reduced cardiovascular events in very high-risk patients who had a low bleeding risk. So this is another calculation to look at. So, please. Yes. Yes. Should they down titrate? Yes. Excellent. Excellent point. We routinely see people leaving the hospital on high-intensity statin. They come back on nothing or very low dose. Down titration is never appropriate. Why? The lower the LDL, the better, right? And this has to maintain lifelong. So the lifelong maintenance of very low LDL is a goal. Now the problem is, and I see this issue, the labs are still saying less than 70, less than, these are all random numbers, right? What you have to look at is the patient's risk. So the recommendation also, and we don't have any lab pathology doctors here, if you see a patient with low risk, fine, do whatever you need to do. But if the patient is high risk, less than 70, very high risk, less than 55. And if they're not at that number, they have to go back to the previous treatment. Now, if the patient has genuine symptoms, right, muscle pain, weakness, and so on, then you can do the statin intolerance pathway. Switch to another statin, add ezetimibe and lower the dose. But whatever you do, you have to maintain the magic number. So the LDL for the post-MI patient is the same as the HbA1c. You have to be below that target. You set the target and keep going. Thank you very much. That's a very important question. And the additional parts of the treatment in a post-MI patient or a vascular patient with coronary artery disease are the following, or heart disease in general. If the patient has a low ejection fraction, then ACE inhibitor is not going to be enough, right? You have to switch them to ARNI. You add the SGLT2 inhibitor as a heart failure treatment. You have to have mineralocorticoid antagonist, and here the beta blocker is essential. And remember, we're talking about patients with LV dysfunction, ejection fraction less than 50%, okay? Now, lifestyle. Every patient who's had a cardiovascular event should be referred to cardiac rehab. So this is one of the weight loss and behavioral modification. Remember, the cardiac rehab is not an expensive gym. It's a behavioral modification tool. You're being seen by a physiologist, a nurse, a diabetes educator sometimes, a dietitian at the same time. They have classes, and they teach them to make exercise part of their day-to-day activity. So there's a very nice slide Dr. Fathia usually presents, is the incidence of lack of exercise among people in Dubai. And then the next picture is beautiful venues that the Dubai government has created for people to exercise. But what's missing in those venues? The people. They don't exercise. Where do they go? They go to the shisha places, they go to the restaurants, right? That's the issue. So you have to change the mindset. Exercise is like a pill. In fact, there's data from the cardiac rehabilitation literature People who do cardiac rehabilitation have 15% less events in the first year. It's as powerful as a statin. So it has to be incorporated in some way. It changes the way mindset. Next, weight loss is part of that. And then there's two additional points that I think we have to touch on briefly. A type 2 diabetic who's obese and has heart failure with preserved ejection fraction. This is one of the most difficult ones to diagnose, isn't it? Because the patient has an echo and the echo says normal ejection fraction. But which one of the tests that we showed in our cardiometabolic guidelines will expose this problem? The NT-proBNP. So I told you this patient's ejection fraction is 55. How do you know he doesn't have heart failure? He's sedentary, he's not going to exercise. If the NT-proBNP is high, this patient has a stiff ventricle and HFpEF. HFpEF is commonest in people with what? Diabetes and ischemic heart disease, right? So you have to assume that this triad is probably there. And here, GLP-1 receptor agonist and metabolic surgery have a very prominent role. The next one, which is going to be briefly mentioned only, is this one, atrial fibrillation. So if you have diabetes, coronary artery disease, hypertension, and obesity, your likelihood of atrial fibrillation goes up significantly. And it's actually been shown in the DECLARE study, very interestingly, that in the DECLARE study, new onset of atrial fibrillation and recurrent AFib was reduced as well. Is this SGLT2 inhibitor some strange antiarrhythmic? It's not. It changes the structure of the heart. It helps people lose weight. It decreases the renin-angiotensin system and the sympathetic nervous system. So it reduces some of the triggers of atrial fibrillation, as well as treating the diabetes. So it's just proving to us that the SGLT2 inhibitor class and the GLP-1 are doing something in the heart that we never had access to. And that's why they've been so prioritized in all the guidelines. Doctor?
Thank you, Dr. Hani. Two comments, please, if you allow me.
Sure.
First of all, in the combination therapy in AGL2-ARNI/ACE inhibitor, because you cannot combine ARNI
No,
with
not
ACE.
combined. It's not
Because
combined.
ARNI, ACE, MRE.
No,
you can
it's,
combine ARNI, MRE, beta
no, it's
blockers.
not combined.
I know, of course.
No, it's a
But
spelling
everybody,
error.
when you look at the slide, you think that it's ARNI and
Typographical
ACE
error.
only.
Thank
Okay,
you.
that's one.
Yes.
That's one. Another issue about HFpEF.
Yes.
We have a scoring for HFpEF, H2PF. You can, not only the ejection fraction will determine. We have EA ratio to get the velocity. We have left ventricular mass index. We have the left atrial size.
Yeah.
And we have pulmonary pressure. So ask our cardiology friend not to do echo just to assess ejection fraction. Please do EA velocity for every patient. If you think about HFpEF, which is very common in our population, I have patients with CKD, all of them have PEF, and especially with progression. Thank you.
So thank you for that. So this is one of the reasons why the ESC has combined BNP with echo criteria. The echo criteria, as you said, are not done by many cardiologists. For the general practice audience, if you see an ejection fraction that's normal with a high BNP, this is HFpEF, right? Just to make it very simple, even if the echo is normal. And it's right, you're right. The cardiologists have to dig deeply into the echo and do some of the measurements that traditionally they have not been doing. So thank you. And we will correct this typographical error. Thank you for saying that. Okay. So when should you ask the patient for a follow-up? When should you follow up the patient? Is it going to be annual? Khalas, you've had your stent. Bye-bye. Typical cardiology approach. 6 months, come back for refills only. 3 months, 4 to 6 weeks, or 1 to 2 weeks. So I just want to come back historically to talk about the traditional approach in the diabetes center. Diabetes center, you have to check the HbA1c. That's part of the follow-up, in addition to many other things. So that's why 3 months is traditional. The HbA1c is tagged to the left of the red blood cell. But for other things, you should see the patients sooner, right? Why? Lipid. How long does it take for a patient to have the full benefit, LDL lowering, of a high-intensity statin? 3 to 4 weeks, okay? And that's what was the standard follow-up in most of the clinical studies. So if the insurance company tells you it's too early, you tell them, no, this is in the guidelines. It's in our guidelines, it's in the American guidelines, European guidelines, it's in the guidelines. I am going to check an LDL in 4 weeks, thank you. And then the only other reason to do it in 4 weeks is to emphasize to the patient the urgency of getting all their risk factors under control. If the cardiologist tells the patient, Mabruk, everything's fine with your stent, come back in 6 months for a refill, that completely loses the idea that the patient needs follow-up, needs emotional, psychological risk factor support. So you do capitalize on this point, and I think 4 to 6 weeks is absolutely the right answer. I would bring the patient back in 1 to 2 weeks if he was a heart failure patient that I'm titrating heart failure medications, if they're having recurrent symptoms, or if I tell them you have residual disease and we're going to do what's called a stage PCI. So that may be a little bit early. So this, you're going to see a lot of times in this workshop. This is the circular approach. And I very much like the statement that Professor Hassanay mentioned the last couple of days. Why is it a circle? Because there is no beginning and no end. Each one of these is equally weighted, right? And I think this is the key point. Glycemic control with specific risk-modifying agents. What are the risk-modifying agents? Those that are mentioned with evidence. And which are those? Can anyone tell me which SGLT2 inhibitors have evidence of cardiovascular benefit? All 4 of them, right? Canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. All 4 have cardiovascular benefit, primarily heart failure and also renal. Which GLP-1 receptor agonists have cardiovascular benefit? And dulaglutide. And also albiglutide, which you haven't heard about because it's been pulled off the market, but it did have a positive study. There's also another one called epfiglinitide. Did I say it right? We don't have that. Now, there is one GLP-1 GIP receptor. Yes. Does that have cardiovascular evidence? It does not. Tirzepatide. Okay? So remember, if you see a patient with this profile, you have 3 medications that do have cardiovascular evidence. You should not be using, until there is evidence, anything else. Use what's on the table. Because we're talking about cardiovascular evidence. The prioritization here is cardiovascular outcome. And I know tomorrow morning you will have 10 patients knocking on your door telling you, Doctor, I want my Mounjaro. Sah? Give me a prescription. I'm going to get it from the pharmacy. So the answer is evidence-based. You need to be on A, B, C, and D if you have cardiovascular disease, right? I think that's very fair. We should not get, the social media people to push us in the wrong direction. Now, target LDL. Remember 2 numbers, 1.8 or 1.4. But the point is less than, okay? Platelet inhibition. Aspirin secondary prevention, so please don't stop the aspirin if you're not sure what the cause is, but if it's purely primary prevention, you can. Now there's another approach which we didn't have time to talk about, it's low-dose rivaroxaban. The COMPASS study showed that in patients receiving aspirin versus aspirin and 2.5 milligrams of rivaroxaban, there was a 40% reduction of cardiovascular events. But there's an increase in some bleeding risk, so you have to have a risk-benefit analysis. Finally, I think lifestyle modification and cardiac rehab. Blood pressure control. You have to use RAS blockers. Even if the patient is not hypertensive, the RAS blockers reduce the improve the long-term survival and are renally protective. And there are multiple targets, but almost all the guidelines have settled on this number, 130/80, for patients who have had a cardiovascular event or very high-risk diabetics. So this is the cycle of reassessment, because in the end you have to reassess. Whatever you do, you have to make sure something happens. So this guy missed 2 years of follow-up, and I think this is why he ended up with the event. So if you are undiagnosed asymptomatic, these patients go to annual screening or screening every 2 years with the essential tests. If you are diagnosed, you have to follow the pathway and you have to be reassessed again annually or more frequently. And as Dr. Hassanay mentioned, the annual performance review becomes the annual clinical review. The items that are seen here are just triggers for you to remember. A patient with target organ damage, or an abnormal ECG, or kidney involvement, or overt heart failure, or an abnormal ABI are patients who are what? Target organ damage equals very high risk, right? So that's the first layer in the algorithm. If you have target organ damage, start treatment, refer, okay? If you don't, we're gonna do the score. So it captures patients from both ends. And I think the most important point is this. Remember the NT-proBNP. Cutoff points in your lab values are wrong. They're gonna tell you 300, 600, 900. That is for acute congestive heart failure. In the outpatient setting, the validated values, these are validated and clinically referenced in the ADA book and ours, more than 125 if you're using NT and more than 35 if you're using BNP. Ankle brachial index is a bedside test. Bedside test. You don't have any specialized equipment, right? Just the blood pressure in the cuff, in the arms and the legs. And you have to do it. It's very easy. It will determine now the presence of atherosclerosis. It's not to send patients to vascular surgeons. It's to determine the cardiovascular risk. That's about it. Thank you.
Any question for Dr. Hani? Dr. Hani, still you have some question there.
Dr. Hani, good morning. Very nice presentation. I want to know something that since there are drugs already which are oral, and the GLP-1 is injectable, it's also orally available now.
Yes.
So these are, if they're cardioprotective, why don't we actually start replacing the ancient metformin and all these, and we start with this in the regular practice? That's my question, you know.
Sure. So clearly that's the intention of this guideline. If you identify patients with subclinical atherosclerosis, subclinical heart failure, target organ damage, or kidney disease, they should be prioritized on GLP-1, oral or sub-Q, or SGLT2, depending on the phenotype, right?
But these can be given prophylactically, like in patients who don't have retinopathy still, but they're having this disturbance in vision.
So the next point is this. Once you do the screening, you have to, so the point is you can't assume, you have to do the screening. What is recommended is all patients get screened, at least annually or semi-annually if not, or twice a year. If they fail the screen, i.e. none of these high-risk features are present, then you apply the score, right? It's not possible to give every single patient a GLP-1 receptor agonist. It's not possible. No, because the data doesn't support that. In the clinical studies, they enrolled specific phenotypes, right? Patients with heart disease, patients with obesity, patients with heart failure, patients with CKD. So right now we have to follow that. However, I anticipate as more and more patients are seen and we have expansion of the data through real-world data or evidence, then that might occur. But right now, the focus is primarily on patients that are likely to have complications, highest risk, highest benefit. Remember, cost is not neutral. I mean, I understand this is an issue. The guidelines are also have to align with what the country can provide. If we take every single diabetic patient from the moment of diagnosis who is very low risk, using some medications may not be effective, right? So there are some patients who are still low risk. I acknowledge I don't see those patients. I'm a cardiologist. I don't see the low risk patients. They are referred to me when they have a problem, but my diabetologist colleagues see them at a different stage. Maybe Dr. Hassanin can also jump into that. So the question was, why not use the disease modification from the beginning, at the moment of diagnosis, all patients?
Is it just the price point?
Yeah, it's a very valid question, and at the end of the day, you will see that in the fourth case. So on the fourth case, we will have a patient who is not very high or high, and then the options you will decide. Basically, without delay, is you do what is indicated for the patient. If the patient has very high risk, use drugs for very high risk. High risk, use drugs for high risk. Neither, then look into the profile of the person and use the drug that will address the profile of the person.
In this, how many milligram is the one recommended? Because now they've come up with something which is, I believe the weight loss is a different dosage, and the other one is a different dosage. Insurance is approving the Ozempic with the low.
We'll come to that in the fourth case, inshallah.
Okay, doc. Thank you. Anybody else?
Question? If no more question, okay, please, go ahead.
Thank you, Dr. Hani. So I'm glad that there's a cardiologist. So my question is, one of your colleagues have mentioned now they've added the NT-proBNP and the ABI. I feel like an echo should be included as well. Possibly at least for those who have type 2 diabetes duration of possibly more than 5 or more than 10 years. Just your thought on that. And my second question is the IMPACT MI trial, which looked at Jardiance 10 milligram once daily versus placebo. There was a 10% relative risk reduction. But then in the primary composite endpoint, which was time to first hospitalization with heart failure all-cause mortality, which did not reach statistical significance. So your comments and what can we gather from this? At least we got one information that SGLT2, empagliflozin was safe in these group of patients, but then just your expert opinion. Thank you.
Thank you. Two excellent questions. So we can't do an echo on every single diabetic. That would literally, that's almost, or pre-diabetic also, that's almost 3 million people. So let me just give you, there's a statistical, I'm not even talking about the resource utilization. In the Canvas study, which was a diabetes outcome study, where they had patients who were high risk and also primary prevention, this is where the 125 came from. It is actually evidence-based. So using a cutoff point, they moved it from 300 down to 125 to include more people in the outpatient clinic. And with 125, the sensitivity is extremely high, and you missed very little people who had heart failure. So it's a very effective risk stratification tool to go to echo. So that's why we said, if you do the BNP or the ECG, anything is abnormal, start treatment with SGLT2 inhibitor and RAS, and then refer, right? So it's a very effective filtration mechanism. Now, I can tell you from a pragmatic standpoint, you don't need an echo to treat with an SGLT2 inhibitor. I'll tell you why. The heart failure preserved ejection fraction studies, all of them, EMPA and DAPA, and the heart failure and the kidney studies, essentially the same thing. If your BNP is above 125, you have heart failure with preserved ejection fraction. And if you're diabetic, you need the SGLT2 inhibitor. It's very simple. So regardless of the ejection fraction, adding an SGLT2 inhibitor makes a lot of sense. For the cardiologist, though, an echo is needed if I'm going to start Entresto. Entresto is useful if the ejection fraction is low. It's important to have an echo if you're going to have an ICD or decide the patient needs to have a cath. So for more advanced procedures, echo is needed, but for the primary physician, BNP in, SGLT2 inhibitor. That's it. It's a very binary process.
Yeah, thank you. It's a very important part. All what's here is based on strong evidence. And we need to remember that in the country, between diabetes and pre-diabetes, collectively 30% of the population, we cannot afford, I mean, this is already pretty expensive, and some insurances are struggling to accommodate and to accept. So if we keep lowering the bar, we will miss so many patients because of refusals. Let's at least do this comprehensive review. Do the ECG for your patient, do the BNP, pro-BNP on an annual basis, and that will filter a lot of people who are undiagnosed. Because if we do a CT calcium score or echo for everyone, that's 30% of the population. Can we do it for 3 million persons in the country?
And we don't want to delay treatment to get an echo. So think about it. You see a patient, you're suspicious. You then send to the cardiologist, you have to get a waiting list, and they get the echo, then the echo comes back. That's months before something happens. And then the cardiologist won't even remember why he sent the patient, right? On the other hand, and I'm serious, I mean, this is how it is, right? We don't have a good EMR for, communication. On the other hand, you send the BNP in your clinic, it's done quickly, it's elevated, khalas. I know this patient has a phenotype that benefits from SGLT2 inhibitor, started. So we're trying to reduce inertia and offload the healthcare system. So does that practically answer the question? The second question of the impact study. So we were actually all very interested in impact, right? Because we were thinking if ACE inhibitors improve outcome early and late in patients post-MI with or without LV dysfunction, right? It's a primary indication. Can we use SGLT2 inhibitors in the same way? So unfortunately, and I think it's because of the modern era, we're using PCI a lot. Revascularization is tremendously impacting ejection fraction. So because they enrolled patients regardless of EF, I think that was a wash. Now, clinically 10% is significant for me, but statistically it will not allow them to get that claim in the FDA. So what you have to do is, if you have a post-MI patient, I look at it like this. I'm looking for reasons to put patients on SGLT2 inhibitors and GLP-1 receptor agonists. I'm literally exploring ways where they become eligible because, as you said, these are life-saving. If it's a secondary prevention patient, we've already missed the opportunities, so we have to look harder and push the insurance harder. Do you see what I mean? Thank you. Those are great questions.
There's a question here first.
Can we just have a question here? Oh, please, go ahead.
Okay, in this patient, is there any chance that his slight low GFR can be a deep response for GLP-1 or SGLB treatment?
So this patient was not on an SGLT2 inhibitor.
Yes, he is in GLP-1.
And he wasn't really taking the GLP-1. Now, we don't see a GFR dip with GLP-1. So just to be clear, right? So the GFR dip occurs with RAS blockers, so ACEs and ARBs. We see the GFR dip with SGLT2 or both. But this is actually a good thing. People have described this. I think Cherney's paper after the ertugrulfloxacin study, Vertis, described people who did have a dip and people who didn't have a dip. Those who didn't have a dip actually had less benefit in terms of heart failure and long-term renal outcome. Those who had a dip, it's actually a marker of restoration of tubular glomerular feedback. It's actually a good thing, right? It's a positive response. So I don't worry about it. In fact, if I see it, I tell the patients within 2 or 3 months, it's going to go back to normal and it'll protect you from long-term kidney drop.
Okay,
I mean,
how much dip acceptable?
so, I mean, I don't know there's a specific defined number, but I'm going to tell you, even if it drops, if the GFR still remains within the normal limit, right? 30?
Up to a 30.
30% drop? No, 30,
Up
30
to
points.
a drop of EGFR of 30.
You can still continue the treatment. Now, for me, I see heart failure patients. Now, remember what's the heart failure getting? Diuretics, MRA, RAS blocker, Entresto. These get a bigger dip. But in the end, after the cardiac output improves, everything gets better. So this is an opportunity, really, to see the patient more closely, but I don't really worry about it that much. In fact, what I usually do in that situation, I delete the diuretic. I remove the Lasix. If the patient's on it, or if the patient's on indapamide or some other HCTZ, I remove that. Because you want to keep this medication on as long as possible, right? And I think the data from the renal studies, such as Credence, which showed very low GFR. And Credence enrolled patients with very low GFR. These were almost pre-dialysis patients. And their cardiovascular event rates were reduced by even more, right? So I know everybody follows the labs and we have to sort of respond and the patient gets very nervous. What's going on, doctor, my killer, it's fine. You can look at the microalbumin, you'll see that actually improves, and then over time you see it improves too. So I think we just have to understand how the physiology works and reassure the patient. But yes, any numbers going in the wrong direction are often alarming, right? We have to react to numbers. Thank you, it's a good question.
Thank you very much. Thank you very much. We're going to break for 10 to 15 minutes, and you have plenty of time to ask when you come for the third and fourth case. Okay? Thank you.